Hello and welcome. We're very excited to have here today Professor Andreas Zuckermann from the Medical University of Vienna, Director of Cardiac Transplantation and immediate past President of ISHLT. Thank you for joining us, Andreas.
Good afternoon. Thank you for inviting me.
So glad you could make it, be here in person. I wanted to start by actually asking a little bit about how you started in transplantation. Where did you get the inspiration of all the medical fields to get into transplantation?
Yeah, actually, it's a long story and long ago because I'm here for more than 30 years. When I was a student, I was quite interested to do some research. And at that time, I was particularly interested in immunology. That was just the beginning in the mid-'80s of transplantation. And in the student newspapers, I found they were looking for students who would work in the science lab on transplant immunology. And interestingly, I tried to get this job, but the secretary said, "Oh, we already have enough applicants." And luckily, I met somebody who was close to the guy who started this lab. He said, he got in contact with us. Said, "Nobody has contacted me. I'm still looking for this person." So I stepped in. And although I wanted at that time to become a plastic and reconstructive surgeon, I was really taken away by these immunological problems and challenges. And we did some studies where we looked at blood of patients, rejection, non-rejection. And I just got to know these patients by the blood vials. I had names and I saw the lymphocytes of these patients, but I was really interested to see how these real patients look like. And then I had the chance to, when I graduated, to become a transplant coordinator, which is very unusual for Americans, doctors to become transplant coordinators. But at that time, Austria produced too many young doctors, and a lot of them stayed unemployed. So I was lucky enough to get this job as a transplant coordinator, and I wouldn't sit here if I wouldn't have done this. It helped me a lot, and I totally got into that. I met these patients, I saw the procedure, and it was quite cool for me as a young 26-year-old to go on these transplant runs, procuring hearts, getting back in the middle of the night, in the middle of wherever you went. So it was a very cool time. And with that came more and more interest in the clinical treatment of the patients and in the science of transplantation. And I got stuck in there. I started, some years later, I started cardiac surgical training, but it always stayed in the area of cardiac transplantation until the current day.
Well, can you tell me a little bit about that first procurement you went on? What was it like?
Yeah, so it was like, it was in May 91. May 91, we went to Germany, to Berlin, to procure a 60-year-old heart. 91, a 60-year-old heart. And I was just amazed. I thought all the organ donors are much younger. I said, "Oh, the 60-year-old looks good." And we went there to Berlin the whole night. We procured this heart, came back in May, so sun was coming up, and I said, "Wow, this is a cool thing to do." And I remember even my second procurement, we went in. It was in close to Leipzig, Germany. Still, all these airports were like in the East German communist system. So I remember when we came back with the organ to the airport, it was closed, and nobody was there to open it. So we had to climb the fence, get the heart over the fence, and run to our airplane and get on the airplane. It's unbelievable, unbelievable. I thought 2 years earlier, I think I would have been shot doing that, but nobody was interested.
This is what hooked you to do transplantation, climbing over a fence with a heart.
That was really an experience. I said, "Wow, this is totally crazy." You do things that nobody has. I think one of the last adventures in our civilized medical system is going out for transplant runs, and I did this for 2 years, just going for almost all the procurement runs. I learned a lot. I even was one of the surgeons trained to procure hearts, even at the very early stage. I had to be an adrenaline junkie to do that.
I think that's got to be part of it because it's so intense and such a time constraint. In terms of knowing Paragonix, you've been working with Lisa and the company for quite a long time. Can you tell me how you first met Lisa?
Actually, she contacted us. She was in Austria. She is Austrian.
Yes, she
and
is.
she was very interested to hear the thoughts of the Austrian transplant community. Although she told us, I'm working in the U.S., but I'm still quite interested in what the Austrians are thinking. And she had this, I would say, this thought, this idea. Okay, I started in America, and I want to have the Austrian center somehow be attached to that. And I met her actually at the Prague ISHLT Prague meeting 2012, and she told me about the first ideas how the Sherpa would look like. And personally, I said, okay, what should it improve, or how could it be better, temperature control or whatever. So I said, but nevertheless, any new idea should be supported. And I said, okay, whenever you're ready, tell us. We would be interested to cooperate with you. I did not know if I would ever hear from her again, but then I met her at several meetings, and she showed me the prototype of the Sherpa and so on. And it all really then started clinically in 2018, when she approached us that they now have the Sherpa pack, and she would be interested what we would think about it clinically, and we got some of the Sherpa packs and used them. And I told her right from the beginning, well, if you want to get into our not market, but that we trust that this is a thing that we would like to work with, I first will test it out in hearts that I normally are reluctant to take. So really extended criteria donors from a European setting. This is very far off. So a donor heart from a person who died in an avalanche, of course, cooled down, of course, but was resuscitated for about 60 minutes, CPR, and when we procured the heart, it was functioning well. Or others where we had really old age, high dose of inotropic support, and other risk factors. And after about 10 uses, we said, okay, we think these hearts that we accepted. Of course, we had also some primary graft dysfunctions with them, but not to a high extent that we would expect from these donors. And I said, so this could increase potentially the numbers of donors that we might accept. And this is when it all started 5 years ago.
And that was part of the impetus for the Guardian Registry, wasn't it?
Oh, yeah, absolutely. So when I remember in 2019, I know that Sherpa went to the market, and I had a conversation with Lisa, and she is a scientific person. That's pretty clear. She's a scientific person. And I told her, if you want to get your foot into this field, try and please do it. Do some science, not just try to sell it, because sell it to people, I think it's a good idea, and we're this and that. This is so the PR department is important, but you have to produce science. And as you won't do a prospective randomized study because you already got approval in Europe and got approval in the US, then try to catch as much data as early as possible before hundreds of centers start to use it, and try to get them to share data together and build up whatever registry. And that was the start of Guardian. And I remember I feel a little bit like a grandfather to that, because I gave some ideas to the Guardian. I said, bring in granular donor data, bring in recipient data, take some risk scores for the recipient, for the donor, so really that we can compare donor risk, recipient risk between the two patient population, and don't just use Sherpa in this registry, use also other conventional areas to preserve a heart. And luckily, it was done. I remember in 2019, there was the ISHLT meeting in Orlando, and Paragonix did the first satellite symposium. This is where I got introduced to David D'Alessandro, who I did not know before. And there the registry was started. I immediately invited David to be part of this registry, and he said, okay. And I remember he asked me at the panel, I said, what I'm going to have to do for that? So do I have 15 hours a month to work at this? And I don't know. It's just get these things running. And I think it was a very good beginning. And of course, it took some time to bring the data together. And And I remember in the first post-pandemic ISHLT meeting in Boston 22, when you presented the first data, I remember was sitting again with David together, and we both looked at each other and said, we never thought that these results would be out there. We are really excited to see this. So we're still puzzled by the impact, and I think we also, all the scientists and doctors who are part of this registry really took a good care to really evaluate the different, especially the endpoints, primary graft dysfunction, use of ECMO, and we recounted, rechecked, and we pushed you guys to do good science with that, and this was really happening well. So I'm pretty happy that we could bring up some lights into these very difficult topic of preservation, primary graft dysfunction, and of course we have to learn, of course, to understand why this is working like it does, temperature control and all these things. And I think this is something also exciting for the future to do some research in this area.
Absolutely, absolutely. I think there's still a breadth of research and science to be done on understanding just some of the mechanistic basic science. But as you're saying, I think the registry approach, and I have to say thank you for your vision and insights on at the early stages of the registry, has really been effective to answer not just one question, but many questions. We get questions all the time about, hey, I'm interested in looking at this combination of risk factors on the donor side, or this combination of risk factors on the recipient side, or this matching set of risk factors. Even like we worked on last year, things completely unrelated to our product or our company, on just better understanding of transplant and preservation and early postoperative course, which I think we're able to do that partly because of the breadth and granularity of the data that it really came out of the original foundational work setting up the registry.
Oh, absolutely. I think one of the important points that we all learned was we're all working with the ISHLT consensus on primary graft dysfunction that actually was based on a consensus conference that John Kabashikawa and I did in 2013 at the Montreal meeting, which was a very exciting because it was the first time that people openly discussed primary graft dysfunction. In the earlier days, you would receive never this honesty about primary graft dysfunction. When you talk to people who said, never heard about this. And I remember I wrote an editorial in a European Journal of Cardiothoracic Surgery on primary graft dysfunction, Mirage or whatever, and I wrote there the real truth is behind is below the surface, and if you want to really know this from some colleagues, they only tell you the stories behind closed curtains or after one or two bottles of wine, maybe. So then people, but these are real stories. They said, and then when we both got drunk, these people told me, oh, well, I had this case. And so I said, hey, you told me you never had this. Oh, we had this case. So I thought this is happening, not just to us, it's to others as well. And we need a good definition. And this was the first definition that finally was done by John and the rest of the consensus group. And but based on the work with GUARDIAN and also other studies, we found out, well, we need to fine-tune it. There are some things that we still do not completely understand that are not that well defined with the current consensus. This is why we did the updated consensus conference at the ISHLT meeting in Prague, and we're really looking forward in after tackling all these questions that have been raised based by other analysis and other preservation technologies to answer it better and find better endpoints for the future to work with also in the registries in this area. And I think this is very important that also the field has to develop. And the GUARDIAN Registry was one puzzle piece that helped us to understand we need to update this consensus. And I think it should be a living registry, and we should maybe look at some other endpoints in the future, but it's moving, and we are learning, and hopefully we are improving in the future.
And I think partly because transplant and you and I have talked about this before. Transplant is such a small place relative to other areas of medicine. The collaboration across centers, across countries, it becomes that much more critical to pool data because the field is evolving quickly. And in order to get enough data and see the changes and see the impacts of these different effects, it does feel like that collaboration and that tight-knit community becomes all the more important.
Oh, absolutely. I totally agree. The times are over when you could do good studies as a single center. The numbers are not big. Well, in the past they weren't really big either, but everybody did his own thing. But we learned if we really want to find the truth, potentially the truth, we need to combine as a combined force to tackle these problems. It's not possible just to do it a single center with an institutional dogma. You have to use this or that. There is the current need to discuss on a very high level between experts on tough and challenging topics like primary graft dysfunction preservation. I think this way to let's say move next to each other, discuss with each other on that topic, bring in different ideas to each other. This is the only way to go, and you need numbers, and with the numbers you have to cooperate. But I think that the task to improve the overall setting is so strong now that even the biggest, I would say, I don't say egomaniac people, let's say the biggest people who just want to things by their own, understood you just can move the field forward if you connect with each other and move together in a combined effort. And this is what we brought together at Guardian.
Which has been just a fantastic experience, and I've personally enjoyed working with all of the investigators and working with yourself to continue to ask interesting questions, to push on ensuring the integrity of the data, so that we can continue to move the science forward. And I think one of the interesting things right now, due to sort of the both the volumes and the usage model that we're seeing and the participation, a lot of the data out of the U.S., but recently we worked together on an extended criteria paper, particularly because the donor pools in the U.S. and Europe are so different. Can you speak a little bit to what the European heart transplant experience is as compared to U.S. donor pools?
So it's a different world. We're not just several thousand miles away from you. It's a totally different world. The donor population is totally different. Our donors are significantly older. They die of different causes of death. As at one point, which is pretty clear, you have an opioid crisis in the U.S., which does not exist until now, hopefully never does, in Europe. So we do not see these donors in a high rate. So most of our donors die of cerebral vascular accidents. A lot of them not treated hypertension, which led to bleeding in the brain. So not treated hypertension, of course, has an impact on the heart, the potential donor heart. So we have to struggle with hypertrophic donor hearts, which are totally different in preserving than a normal 25-year-old donor heart. And the push to transplant the patient is so strong, especially in the Eurotransplant area, that in Eurotransplant, about 77% of the donor hearts are accepted and transplanted that are referred. And the average donor age, or let's say the median donor age of those that are transplanted is about 46, 47 years. Compared to the U.S., where only, I think, 44% of the donor hearts are accepted and transplanted, the donor age is significantly younger. We just recently published in the European Heart Journal an analysis where we compared U.S. data versus Eurotransplant data. It was a combined effort of Stanford University, us in Vienna, and Eurotransplant. And we pretty clearly could show the differences of the donor population, the differences in the acceptance. And we also did this analysis, what would happen if the Americans now switched to the European way of accepting donors. Then you wouldn't have a waiting list anymore. However, I have to say, we do not have this very strict and strong it would say quality measures. So I know in the U.S. if a center has a certain amount of worse outcome after a certain time period, they're closed down or people are thrown out. And so the push to accept extended criteria donor hearts is not as strong as in Europe. So this is definitely a difference. But we have somehow learned, especially in Vienna, to adapt and trying to protect these extended criteria donor hearts pretty well, because our outcomes in Vienna are close to or similar like most of the American centers, with more than 90% 1 year outcome.
And one of the things you referenced there, and I think is also important from the U.S. perspective, we're operating in the U.S. under a single transplant system. Europe's not one place. Eurotransplant is a few countries in Europe, but there's also Scandi Transplant, as well as quite a few of the large countries that have their own independent system that aren't part of a multinational system. Isn't that right?
Yeah, that's absolutely correct. So the Eurotransplant is the biggest allocation organization where donor hearts are shared between different countries, and one of the few ones. Scandia is also another one where you have different countries connected to each other. But France, UK, and Italy, they have their own and do their own thing. Of course, the exchange of donor hearts between those different organizations is happening, but to a very low extent, mainly in pediatric donors, because there is a need, and some of the countries do not have these higher numbers of pediatric recipients on the waiting list, and partly also with extended criteria, or let's say small blood group AB donors, where even sometimes in the big countries you don't have the right recipients, and then you try to share. But besides that, it's only within this organization. Partly also because, not that many people like to go from Vienna to northern Sweden to collect the donor, because it's a long distance. Maybe with the use of new technology like yours, this is going to be more easier to do.
No, absolutely. Can I ask you, in terms of that, in terms of new technology and new forefronts, what do you see the big challenges in transplant ahead of us, and are there major forefronts that are particularly exciting for you in terms of new advances?
Yeah. So I think one of the challenges definitely is and will be clear understanding and the legal and ethical framework on DCD transplantation. We have a lot of discussions going on, and within the ISHLT, we now have implemented a task force on normothermic regional perfusion, because there is a lot of discussion out there, and we need to get this discussion inside of our expert groups, but also cross-talk to neurologists, cross-talk to ethicists, cross-talk to intensive care people and anesthesiologists. Is really important to understand each other in a better way and bring out a clear statement on how it should be done and what is ethically acceptable. And I think one of the front runners here, we're going to an air like being really, really far advanced are the Italians. You wouldn't know the Italians because in Italy, donation of the testicular duct transplantation donation is only after an observation time of 20 minutes.
Right.
And in Austria, it's 10 minutes. So most of the countries have 2 or 5 minutes. Yeah. And when we started our DCD program in Vienna, I would say the big guys like in Australia, Peter McDonald's and Stephen Large from Cambridge warned us like 10 minutes might be too long. But we worked it out. It worked. And now the Italians have 20 minutes. And last year they started NRP transplantation of hearts with 20 minutes. Gino Gerosa from Padua was the first one to do it with an excellent outcome, and not with a 25-year but a 50-plus donor. And now several other Italian centers followed with similar good outcomes. So this is something that could change. This is exciting to see that we could protect the heart even on a longer run. Another thing, of course, is what we're going to do. What is the perfect way of preservation, especially in extended donor hearts? How could we improve the current status of preservation, which is actually 50 years old? Just put it in the ice bucket and use whatever cardioplegic solution that mainly focuses on the cardiomyocyte. We don't have any understanding what happens to the endothelial cells, and I think they're very important as the first line of contact with the blood of the recipient and the immune system. The question is what will be the preservation of the future? Would it be machine perfusion, warm, cold? Would it be temperature control or intermittent perfusion? So it's a very exciting field over the next years. So I'm really looking forward, and I try, of course, to push my group into the center of this field because it's so exciting, and it hasn't been there for many years. It was all just long-term follow-up and these things, and now we surgeons are back in the game. So the meetings are full of that. But I think we have to put a big effort that it's mainly driven by science. And now we learn that a lot of the dogmas that we have built up over the last 30, 40 years in cardiac transplantation are based on a very low-level data and evidence. So I think we have to go back and better understand what kind of temperature is good. If we do perfusion, would it be permanent? What is the best solution? So there are a lot of things exciting and studies going out. So for the clinicians it's exciting, and also for the basic and translational research is exciting to help us understand better what a donor heart really needs. And does a 25-year donor heart need the same protection as the 55-year or hypertrophic donor heart? So I think it will be more individualized to use different technologies for preservation in donor hearts. Makes it more complicated, but I think this definitely, I guess it will be more also an individualization to see what is the best protection of a donor heart in this current setting here, there, area. So this is something I'm really looking forward. Unfortunately, I'm now 30 years in the game, so I'm pretty old for that. So, but I love to look at what the young people will do in the next years, and it's really exciting.
And to that, at the medical university, you're constantly working with young attendings or medical students and fellows. How do you approach teaching? Because it's so interesting. There's obviously all the technical skills, all the medical knowledge, but also the research and the cutting edge of transplantation, and in a field that is currently going through such flux and new innovation. Is exciting. How do you instill the excitement for research and pushing the field forward in the next generation?
That's an important and not so easy question. So I can tell you, students and young fellows, residents, cardiac transplantation, our center still is sexy. They like to do it. They like to be involved in it. Similar like when I was young. This is cool. This is gonna do this. So every year I have several students approaching me. Oh, I would like to do some science in with you. And said, okay, great. And then there are some residents who want to be what we call the transplant fellow. So this person is 1 year in my team. They're not in routine cardiac surgery, just in transplant, do all the procurement runs. We assist them, the transplants, unless they are really difficult cases. So we supervise them and train them to become ground transplant surgeons. And I push them to do some science. And you know that the publication on extended criteria with the GUARDIAN Registry is one of my fellows, and I pushed her, said, you're going to do this, and she did it pretty well. So sometimes I feel you have to kick these young people a little bit to do that, but of course, as I call it, intrinsic motivation, like I had in my own way, is something you have to search for. Mining for a heart of gold, as you would say, and trying to search for that. But there are enough young people out there exciting about that. But you have to make them understand excitement is one part, it's the first part, but then you have to go through quite a time where you need a lot of work, persistence, breath to get through this, to go to the end and change the world. When I was young, it was immunosuppression, and I was growing up and becoming one of the experts in immunosuppression. And then now I changed to this other area, and I try to hand over this excitement to the younger generation. And I hope I can keep this running.
Absolutely, and I really resonate with what you're saying there because in my own experience, I've been involved with product development and new products, and very similarly, those early phases of the projects are always extremely exciting. It's everything's possible, very exploratory, looking at new possibilities, new technology, and the as you get into the project, then it's work, and you got to do everything right. We're in regulated products that are life-saving devices. You've got to make sure everything is done perfectly well, and it takes persistence, and you face challenges, and getting through those and keeping teams motivated through all those periods to make sure we keep the patient in mind and make sure we deliver the best possible product to make that impact. That both sides of the equation are really important. The inspiration and excitement, but also then the persistence and work to see it through and deliver the quality that you need to at the end of the day.
Oh, absolutely agree. I remember I did the first machine perfusion transplantation in Austria in 2007, and I was also involved in our first DCD heart transplant, in the German-speaking countries. In 2019. So the excitement was the whole team. It was vibrating and everything. But the real big point is to get it included in your routine work area. When the excitement, so if you're going to the 50th run or something, when it just becomes routine, and keep the push going and tell them, okay, now it's routine. Now you have to do this or that. But based on this routine, create something new and bring an innovation with that, what we just implemented in routine. I think this is the challenge, but also the goal for us, that how to move things forward. And as you said, persistence is, I think, one of the most important words in our field.
Absolutely. I mean, especially, there's so many interesting research ideas that come out, but the persistence to see them through into a real change in practice or clinical activity, I think circling back to the GUARDIAN Registry, sort of, everything of the work, like you were talking about your initial experience with Lisa, from the idea to the product, and then to doing the science and the work to show that it has an impact. It's a long road, and that's a real challenge. But I think when it's also incredibly satisfying when you're starting to see the real benefit to patients and the real impact to patients at the end of the day. That's where
I totally agree. As when I compare it to sports, building a winning team by getting the right rookies and getting the best free agent is possible. Yeah. It's possible in our system. So creating a running system, a running good transplant team, or a register, whatever, is possible. But transforming it into a dynasty, so you are on the top level over years, this is the challenge. But and there you need to have leadership by more than one people who have the drive over a long run to just get up the Mount Everest, get down. It's not easy. You can die, or problems can happen, but going up and down there every year, that's a different thing. And I think this is what we need in this area, to have the constant push to move the field forward. And as a center, as an expert, you need to cooperate with people like you guys, or like companies who have the same feeling, who have the same persistence. So it's like, okay, we want to change the field, not just to earn money, which is, of course, part of your game, but we want to change the field to a better way to help our patients. And this is a goal that we all have together. We want to have better outcomes, and we want to have 100% survival for 30 years in our patients.
Yeah, I remember, and I'm maybe going to get this wrong, but there was a quote that I recently heard of excellence is not one great activity, but it's the sum of thousands small activities done diligently every day. And so I think it's just that. It's we got to collaborate, we got to work together, and then see it through to really make big changes. And I have to thank you for everything that you do, because you touch all these patients every year. And it's an incredible impact. So thank you, and you've been an incredible partner and great person to work with on the GUARDIAN Registry to advance this science.
Thank you. I just can give this nice compliment back because it has been very exciting to work with you guys because from the beginning I had this feeling you are interested in science too, and this is so important for us, not just to sell things but to improve things and listen to the needs of the community, and this is important in our field.
Well, thank you very much. I really, truly appreciate it. And thank you all for listening. This has been another episode of Every Possible Advantage.